Thank you so much for such a kind introduction, and thank you for having me at this year's meeting. The topic of my talk is to give you an overview of the impact of scleroderma on GI tract, and hopefully I can give you a brief overview because obviously this talk can take hours. Okay. So the objective of my talk is to discuss GI manifestation of scleroderma. I'll briefly discuss the pertinent diagnostic tests and specifically what is currently available in BC. And I'll review some lifestyle modification that could potentially impact the gut health. And I'll give you an overview of management options without hopefully overwhelming you. So systemic sclerosis, as you know, is derived from Greek term scleros, which means thickened, and dermos, which refers to skin. It is characterized by damage to small vasculature, which is also associated with inflammation secondary to certain autoantibodies that your body produces inappropriately, and is resulting in excessive scarring due to significant amount of collagen deposition. The prevalence of scleroderma, depending on what studies you look at, could be anywhere between 4 to 490 cases per million individuals. But unfortunately, almost all patients have some form of GI involvement. So on the left-hand side of the screen, I showed you a cross-sectional imaging of how intricate your GI system is, composed of several layers. On the inside, hopefully I can point, on the inside of the lumen, the GI tract is covered by certain cells called epithelium, and then you have multiple layers involving connective tissue, small vasculature, nervous system, muscles that essentially form your GI tract. And in fact, the GI system has a completely separate brain system that is referred to as enteric nervous system. And those intricate nerves interact with the brain and spinal cord. But you have more neurons in your GI tract that you haven't combined in your spinal cord and brain together. And those two systems are closely related to each other. So what is GI motility? So it's referred to as a certain coordinated transit activities that allows the passage of content along the digestive system from the mouth to anus. Involves an intricate interaction between the brain, muscles along the GI tract, the nervous system inside the GI system, which I said is referred to as enteric nervous system. When the movement does not have normal strength and or coordination, that's when the patient develops GI dysmotility. In scleroderma, inflammation within the muscle wall, collagen depositions in the musculature, and likely damage to the nervous system interferes with normal GI motility, and as a result, the patients are prone to developing GI dysmotility. So unfortunately, the list of symptoms with scleroderma involving the GI system is quite long, but many patients experience gastroesophageal reflux disease and regurgitation. In about 30% of the patients, it can actually be asymptomatic. The patients experience difficulty with swallowing, which could be seen in up to 90% of the patients, especially if they have dry mouth, dry eyes, kind of sickle syndrome. And mostly is because of the underlying esophageal dysmotility that can involve around 70 to 96% of patients. Patients can complain of indigestion, nausea, bloating, distension, vomiting, early satiety, postprandial fullness. Because of certain damage to the vasculature along the GI system, patients can also develop ulceration and, as a result, GI bleed. It can be associated with abnormal small bowel movement, and because there's lack of those housekeeping waves that come along the small bowel and clear the small bowel of any residues, the patients are prone to developing small intestinal bacterial overgrowth, which can result in diarrhea and some degree of malabsorption, malnutrition. Anal outlet disorders is also quite common. Many patients may experience constipation, and also fecal incontinence can be seen in anywhere between 10 to 50% of patients. And outside of the luminal GI tract, there are other organs that can be involved, including liver and pancreas, which could be associated with some degree of dysfunction, and it could be associated with other autoimmune conditions, including celiac disease, which can result in malabsorption and, as a result, malnutrition. So the list goes on and on. But as I said, the esophageal involvement is quite common. So without understanding the normal mechanism of swallowing, it would be hard to appreciate why the swallowing gets affected in scleroderma. So on the left-hand side of the screen, I'm showing you just the schematic presentation of what esophagus looks like. So from the mouth, there's a tube that connects essentially the mouth to the stomach, and you have sphincters or valves that separate the oral cavity from your esophagus. So that sphincter on top is referred to as upper esophageal sphincter. Then you have the stomach, and at the bottom of the, then you have the esophagus, and at the bottom of the esophagus, you have the lower esophageal sphincter that separates the esophagus from the stomach. So in order to get the bolus that you swallowed from your mouth all the way down to the stomach, there are a series of coordinated contractions along the body of the esophagus referred to as peristalsis. So the muscles on top of the bolus squeeze, and the muscles at the bottom relax, and as a result, it's kind of like pushing a toothpaste out of a toothpaste tube. So you squeeze it on one end and the toothpaste comes out. So basically your esophagus does similar function. So it squeezes the muscle on one end and the bolus is transferred down into the stomach. And your lower esophageal sphincter has to relax so that the content gets into the stomach. Now, I'm going to go over the esophageal manifestation of scleroderma, which is mainly gastroesophageal reflux disease. And as I said, the patients experience difficulty swallowing, and that's usually because of an underlying movement disorders of the esophagus, and patients could also experience spontaneous regurgitation because abnormal esophageal movement. So what is gastroesophageal reflux disease? Or referred to as GERD. And again, the mechanisms that are placed in normal patient or normal subject in order to prevent the reflux of stomach content up into the esophagus is this barrier mechanism called lower esophageal sphincter. So by definition, GERD is a condition in which the reflux of the stomach content up into the esophagus causes trouble symptoms and also complication. Most patients experience typical symptoms of reflux, which we refer to as burning sensation in the chest, acid taste in the mouth, acid regurgitation. However, there are some patients who may experience atypical symptoms such as sore throat, cough, dental erosions, and asthma. This is a busy slide, but I think it's really important to understand what defense mechanisms are placed and what happens with scleroderma that patients are prone to developing GERD as one of the most common presentations. So on the left-hand side of the screen, you can actually see the mechanisms that are in place. So starting from the mouth, going down towards the stomach, you, as a normal individual, patients, subjects will produce enough saliva. So that saliva clears and lubricates the esophagus, and it also has some neutralizing molecules. So if there's acid in the esophagus, it can actually neutralize the acid. But also, if there is any reflux of content into the esophagus, your body automatically induces a reflux, a swallowing mechanism. There is intact peristalsis or contractions along the body of the esophagus. Also, the cells or the epithelium that I mentioned earlier, they have a tight seal in between in order to prevent any content from getting into the deeper layer of the esophagus causing damage. There is that valve again, or the lower esophageal sphincter, that maintains adequate pressure. And also, it doesn't open up that frequently. Everybody burps. So that mechanism allows the stomach to vent. So it's the relaxation of the lower esophageal sphincter that allows the person to burp or vent the stomach. And then you also have the normal stomach motility that essentially downstream is moving things along without any backlog. Now, what happens in scleroderma, many patients unfortunately suffer from Zika syndrome. So they have dry eyes, dry mouths. So there's inadequate salivary production. And remember, the saliva produces all those neutralizing molecules that actually lubricates things, allowing the food to go down in the esophagus. There's also this impaired reflux-induced swallowing mechanism in patients with scleroderma. And also along the body of the esophagus, many patients experience GI dysmotility with what's usually referred to as weak contractions. So the squeezing is not as strong. And in more severe cases, it could be associated with absent contractility, which practically means that there's no contractions in the body of the esophagus. So it's really just gravity essentially pulling the food down into the stomach. And also with the lower esophageal sphincter, same thing. It is a muscle that gets impacted by scleroderma. So the lower esophageal sphincter becomes quite weak, and at times it actually does not generate any pressure. And also it relaxes too frequently. So essentially it's kind of like a free highway for the stomach content to come up into the esophagus. And also, your GI system is a continuous tube, and by the same token that motility could be affected along the body of the esophagus, the rest of the GI tract could be affected by it too. so that you have the delayed stomach emptying. So things are sluggish in the stomach, and there is only one way to go, the path of least resistance, coming back up into the esophagus. So how do we evaluate the esophagus? There are different ways we can look at the esophagus, and obviously these are complementary tests that each of them provides certain information. So one is the upper endoscopy, or referred to as esophagogastroduodenoscopy. So it is a camera test where it's usually done under conscious sedation. So basically there's a tube that has a camera attached to it, usually done by a gastroenterologist or an endoscopist. So it allows us to look inside the esophagus, stomach, and also the beginning of the small bowel. So we're looking at structural damage. If there's any inflammation from reflux called reflux esophagitis, or if there's any narrowing, or if there's any hiatal hernia, or things like that. The barium swallow, it's usually done at the X-ray department, so where the patient is given a barium, which is essentially like contrast material, like chalk, taste, and then patients drink, and then we'll take X-rays of the esophagus, looking at the movement, looking at the caliber of the esophagus and the anatomy of the upper GI tract. And then the motility is assessed by high-resolution esophageal manometry, which is the gold standard at many centers around the world. And we're also able to monitor the acidity of the content that is refluxed back into the esophagus with what is called pH monitoring, where the patient wears a catheter in their nose and they essentially go walk around, do their normal function for 24 hours. And if they have any reflux, they push a button on the recorder that we provide with the patients, and then we can look at to see if there's any association with the reflux and also the symptoms that they experience. So this is the area that I'm very excited about, so I'll try to content my excitement. But so the high-resolution esophageal manometry is the gold standard for assessing movement disorders of the esophagus. So as you can see, it's a pretty thin catheter, but it's extremely high technology that has so many pressure sensors. So these copper-looking circles are actually where it measures circumferentially the pressure that is generated by the muscles along the body of the esophagus. And the catheter is inserted through the nostril into the esophagus in the beginning of the stomach. And all these points that you see, that allows the continuous measurements of the esophageal contraction. Oops. So this is the lab that we were hoping to establish 16 and 18 months ago, and it took us that long to try to convince the foundation and also the generous donors who support our esophageal motility lab, and also the support of our gastroenterology program. We're finally successful to actually bring the equipment to Proper Vancouver, and up until 2 months ago, there was actually no GI-directed esophageal motility lab in Proper Vancouver. So this lab has the potential to actually serve close to 2 to 3 million people with esophageal dysmotility in the Proper Vancouver, and of course the patients with scleroderma would be a good percentage of those patients who have underlying esophageal dysmotility who will require to have esophageal manometry for assessment of this test. So I've had the pleasure of working with Naomi, who's my nurse, but I'm actually holding the catheter in my hand, and you can see it's pretty thin. So it is a flexible catheter. Yes, the test may not be comfortable for the catheter insertion, but it gives us extremely valuable information that could actually assist with the management of a patient. So what is high-resolution manometry? Remember I told you about the motility of the esophagus, that the bolus is squeezed on one end and it's basically pushed into the stomach. And the catheter has all those pressure sensors that it can measure the contractions along the body of the esophagus. So it gives us a two-dimensional picture of what the esophagus is doing. And the diagonal band is supposed to represent the nice peristalsis that we would like to see in the body of the esophagus. And the higher pressures are demonstrated by hotter colors, and the lower pressure demonstrated by the blue colors or the cooler colors. So that allows me to see if there is any evidence of esophageal dysmotility along the body of the esophagus. And you have two areas of high contraction. So this is the upper esophageal sphincter, so the valve on top of the esophagus, and the lower esophageal sphincter, so the valve at the bottom of the esophagus. And by looking at the colors, I can tell you whether the sphincter is actually contracting properly or not. So this is what a normal esophageal manometry should look like. So you have this upper esophageal sphincter opens up in response to a bolus that you swallow, and then it goes along the body of the esophagus with a nice peristaltic diagonal contractions, and then you have the lower esophageal sphincter that generates a band of pressure, but in response to the swallow, it relaxes, but it comes back to its resting pressure. The purple color allows me to see whether the bolus completely clears the esophagus or not. So that tells me if there's any stasis of the bolus in the esophagus, which could commonly occur in patients with underlying esophageal dysmotility. So now let's look at high-resolution manometry in patients with scleroderma. So your upper esophageal sphincter and the top part of the esophagus is composed of skeletal muscle. So a different type of muscle that is involved in the body of the esophagus. So it's not affected by scleroderma. So you see this is normal. But you don't see that nice diagonal band of contractions that you would expect to see. So there's nothing going on. There's no contractions, right? And then at the bottom of the esophagus, the lower esophageal sphincter is also quite weak. So that's why the patients are prone to developing gastroesophageal reflux symptoms, not only because of the reflux of the stomach content, but also because the food gets stagnant in the esophagus and it causes like fermentation. That's why people may experience reflux type symptoms despite being on maximum medical therapy, because the medication only allows the stomach to suppress the amount of acid that it produces, and it doesn't do anything with the stasis and that fermentation of the food in the esophagus. And you see that the purple color, there's a lot of purple color. It shouldn't be that. So that's because there's actually stasis of the content in the esophagus that doesn't clear the esophagus properly. So they've actually done studies looking at patients with scleroderma to see what is the prevalence of esophageal dysmotility. And as you can see, this was a study done in about 80 patients. And they actually looked at different subtypes of scleroderma, which we don't need to go into details, but you see that the absent contractility is quite common in patients with scleroderma. And then less severe form of it is the ineffective esophageal motility, where the contractions are weak, but at least there's still something there. But it affects at least around 80%, almost 80% of the patients have underlying esophageal dysmotility. And the studies have shown that people who have absent contractility, they're likely to have worse pulmonary function and more advanced skin disease, and they're also experiencing more reflux esophagitis, which is inflammation of the esophagus, and also Barrett's esophagus, which is over a long period of time, the lining of the esophagus starts looking different, and that is referred to as Barrett's esophagus, which could potentially be a risk factor for esophageal cancer, although the risk of Barrett's esophagus becoming esophageal cancer is 0.7% per year. So what are some of the things that you can do? Because unfortunately, there's no treatment for underlying esophageal dysmotility with scleroderma. So what I suggest to my patients that if they have sickle syndrome, make sure you use artificial saliva, gums, drink plenty of liquid and water. Exercise in order to maintain a normal body mass index. And a body mass index, essentially, it's a ratio of your weight to your height, and it should be between 19 to 25. Because that actually, normal subjects shown, if someone has a BMI greater than 25, that's probably the only lifestyle modification that has shown to have significant impact on improving gastroesophageal reflux symptoms. Avoid any large meals at nighttime, generally at least 3 to 4 hours before bedtime or before you actually lie flat. And elevate the head of the bed by 30 to 40 degrees, because as I said, gravity is your friend. Eat frequently, smaller portions during the day. Avoid any trigger food, and whatever your trigger foods are. A lot of people hear chocolate, coffee, mint, things like that, but if you have a different type of trigger food, then try to avoid that. And ensure adequate chewing. Space out your bites. You want to have a small amount of fluid to perhaps clear that bolus from the esophagus. And some suggestion that around carbonated beverages, although a lot of people may feel worsening bloating and distension with that. So the pharmacologic options usually target the amount of acidity that comes up into the esophagus and neutralizing effect of it. So you have over-the-counter options such as Tums or Gaviscon, usually for patients who don't have that much reflux symptoms. There are other medications work by different mechanism called H2 receptor blockers like ranitidine or Zantac or famotidine. There are coating agents, again, like liquid Gaviscon or Sulcrate. But the main treatment options that we pick is referred to as proton pump inhibitors, which are a few of them currently available. But they're all essentially equivalent, more or less. And there's medications like baclofen that it targets usually the lower esophageal sphincter, but because of the side effects, it's usually not as well tolerated. And then we're getting into the sort of off-label territories. They've done studies with buspirone, which is a medication that has been used classically as an antidepressant, but it has shown specifically in patients with scleroderma to actually promote some movement along the body of the esophagus, and it improves that lower esophageal sphincter pressure. And then some physicians may recommend promotilic agents. So these are the agents that promote movement along the stomach in order to empty things. So medications like Maxaran, domperidone, metoclopramide, you may have been told. And there are also newer medication referred to as procalipride or Resolor. That's a medication that is initially actually approved for chronic idiopathic constipation, but it has shown to improve movement along the stomach, small bowel, and also the large intestine. So if someone has problem with early satiety but also has trouble with constipation, I usually try to pick at one treatment that can actually have multiple targets. So I may pick something like procalipride. So there was a lot of safety concern around PPI use, and this is probably one of the most common questions I get around PPI use. Is it true that it's going to cause me have sudden cardiac death, or my kidneys are going to fail, or I'm going to develop dementia and things like that? And unfortunately, patients are misinformed, even by pharmacists, that they're told that, oh, you should stop your PPI, you should not be taking it more than 4 weeks, yet they may not have necessarily the whole picture before they actually make those recommendations for patients. So that is something that you definitely want to speak with your physicians before you decide to stop a medication. So these are actually the New York Times articles that were published not too long ago. But I want to bring your attention to this, that most of the studies that they've used in these articles were based on observational studies, which means that they're not powered to show that these medications actually cause heart problem or kidney issues or dementias and so on. And they're only able to actually show if there is any association. So is there any evidence to actually show that the PPI or the proton pump inhibitor that we commonly prescribe for gastroesophageal reflux disease are actually safe? So we're lucky to have a recent publication by Canadian gastroenterologists out of Western University, that they showed that they reviewed the safety of PPI in a large placebo control. So usually with medications that have been around for decades, they're not going to do any placebo control trial, but they've done that because of such great concern around it. So they've actually had 18,000 patients followed prospectively. So from today, they followed them 3 years, and they wanted to see whether there was any safety concern between the PPI versus placebo or sugar pill. And they showed that there was actually no difference in terms of the safety between PPI and sugar pill up to 3 years in a prospective study. There was a slight increased risk of enteric infection, which means infections in the intestines, such as C. difficile infection, but this was not statistically significant. So what does that mean? So PPIs are safe to be used at a smallest dose that provides symptomatic relief with good control of GERD for the shortest period of time. There's always has to be a fluid discussion between the patients and physicians with regards to the PPI duration and dose, and the patient should fully understand why they're taking it, at what dose they're taking it, and how long they should be on it. As I said, 50% of patients with scleroderma have esophagitis, 20% of them have GERD complications like ulcerations, erosions, narrowing, things like that, and 9% of the patients can have Barrett's esophagus. So in scleroderma patients with significant GERD, the benefit of using PPI, which is to treat the reflux esophagitis, reduce the risk of those narrowing or what we call peptic strictures or Barrett's esophagus, outweighs the risk. So overall, PPIs are considered safe in the setting of appropriate use. So sometimes I get the question around anti-reflux surgeries. So in a healthy individual who doesn't have underlying scleroderma, anti-reflux surgery may be an option. So just to briefly tell you what the surgery involves, essentially they wrap the top of the stomach around the bottom of the esophagus to reinforce that barrier mechanism I told you about at the lower esophageal sphincter. But the problem in patients with scleroderma is that, remember, they don't have much contractions in the body of the esophagus. So if someone takes that and make a wrap around it, they're going to have more trouble with swallowing. Okay, so, and specifically, there's probably less studies in patients with scleroderma with anti-reflux surgeries. They've had patients in retrospective studies that they looked at to see if they've gone through other form of surgeries, where they do essentially what they used to do for bariatric surgeries, whether they would have any improvement on the reflux symptoms. But again, there is also risk of intraoperative complications and other risks that should be considered. So we rarely send any patients with scleroderma for anti-reflux surgeries because of those reasons. So it has to be in a very selected patients as a last resort for refractory reflux. And it has to be through a multidisciplinary discussions between the patients, expert surgeons, rheumatologists, respirologists, and gastroenterologists. So moving on to the stomach, as I said, one of the other symptoms is the delayed gastric emptying, referred to as gastroparesis. Now, the patients may have a variety of symptoms. They may have a little bit of early satiety, postprandial bloating, but sort of pain in the epigastric region, like up part of the stomach, or to complete inability to tolerate anything orally because of severe vomiting. And it could be associated with weight loss, malnutrition, and malabsorption. Up to about 50% of the patients may have diminished gastric emptying and decreased gastric accommodation. Gastroparesis, remember, can also worsen GERD because the downstream is not moving. And generally, we do get a gastric emptying study. So the patients are given an egg sandwich, and then their x-rays taken from their stomach to see how fast the stomach empties itself. And that remains pretty much the gold standard that is currently available in BC to assess the gastric emptying. So what are some of the non-pharmacologic therapies you can try? So just try to minimize medications that slow down gut. There are lots of medications that have side effects on the GI system that kind of slows things down. So you want to try to avoid those medications as much as possible. If you have diabetes, you should have very good control of your fasting blood glucose, because when the blood glucose is high, your stomach does not empty properly. It's important to see a registered dietitian to get some guidance around gastroparesis diet. And eat smaller portions, but frequently throughout the day. You want to reduce the amount of fat and high fiber diet, because that takes time for the stomach to churn and then pass it on to the small bowel. You may need to use some antiemetics or anti-nausea medication for symptomatic relief. And over-the-counter ginger and peppermint oil may actually be beneficial, and is without any side effects. Sometimes we have used prokinetics, so these are the drugs that essentially stimulate the stomach to empty. You may have heard of metoclopramide or domperidone. Again, we come back to this drug called buspirone that I mentioned earlier in terms of promoting some esophageal movement, but it has also shown to improve gastric accommodation. So what that means is that your stomach has to descend in preparation for the food to get inside the stomach. So buspirone has actually shown to improve that accommodation, but there is no specific study in patients with scleroderma with respect to gastroparesis. And again, I'll come to procalcipride. So that has shown to improve symptoms of gastroparesis and enhances rate of gastric emptying in normal subjects. I'm not specifically aware of a gastroparesis study in patients with scleroderma, apart from maybe some case series, which is a small cohort of patients. And erythromycin, sometimes we use it in a setting of hospitalized patient. Even though it is an antibiotic, at a smaller dose had actually shown to promote movement of the stomach too. So sometimes I use it at a small dose, but for a very short period of time because of risk of developing resistant all sorts of bacteria, because it is an antibiotic. Unfortunately, we don't have that many options as a prokinetic agents promoting movement in the stomach, and sometimes we may have to use more like semi-invasive procedures, such as Botox injections in the bottom of the stomach that kind of relaxes the muscle, allows the passage of the food. Ideally, we want to use the GI tract as much as possible because we don't want it to atrophy. So sometimes we may use different form of diet, like semi-elemental or elemental diet, which are not exactly palatable diet, but they're partially digested or completely digested, that essentially allows your body to absorb the food more easily. And sometimes we may use a percutaneous feeding tube in order to bypass the stomach, so essentially pass on the food to the lower part of the GI tract. There's gastric electrical stimulation that has been used in the past. It's kind of fallen out of favor. It's kind of like putting a pacemaker in your heart, because you actually have pacemaker cells in your stomach. And then acupuncture have shown to be of some benefit in patients with gastroparesis. And as a last resort, we may go to parenteral nutrition, where the nutrition is essentially given through IV, but that's really the last resort. So talking about weight loss and malnutrition, usually this is a multifactorial issue, and it's because of the perioral contractions, avoidance of bulky food, underlying esophageal dysmotility, delayed gastric emptying, and also the excess amount of bacteria in the small intestine, which can result in diarrhea, malabsorptions, and so on. Patients may develop weight loss. Recognizing weight loss is crucial in order to institute nutritional support earlier on. And it has to be through a multidisciplinary approach with registered dietitian, occupational therapist, physiotherapist, of course, GI. And it is important to ensure that there's age-appropriate cancer screening with breast, prostate, colon, and cervical cancer. And again, ideally, you want to institute enteral nutrition. And as a last resort, you may go down to other interventions that I talk about. So moving on to small intestine. Now, the small intestinal bacterial overgrowth is a topic on its own, but what does that mean? So essentially, it is a condition that is referred to as excess amount of bacteria growing in the small intestine. Small intestine is actually a relatively sterile environment, so it should be very small number of bacteria, but when the count of those bacteria go up, patients may present with myriad of symptoms, including bloating, abdominal distension, flatulence, diarrhea, nausea, fatigue, and so on. In more severe cases, it could be associated with malabsorption and malnutrition, and as a result, weight loss. And unfortunately, patients with scleroderma do have a few risk factors because of the underlying disease, also because of the certain medications that they're on, and also the PPI to some extent, because it suppresses the stomach acid, may actually provide an environment for the bacteria to grow. But again, as I said, the benefit of PPI likely outweighs the risk in patients with scleroderma. So the diagnosis is by a breath test called lactulose or glucose breath test, but unfortunately, some naturopaths do it. The problem is that they actually measure the breath every 20 minutes rather than every 15 minutes, so they can miss small intestinal bacterial overgrowth, and it is not done according to the appropriate protocol, so it has to be standardized, but we don't unfortunately have access to it in BC. And the treatment plan is to induce remission and, of course, maintain and modify the underlying cause, which would be quite challenging in patients with scleroderma because of the underlying GI dysmotility. This is just to show you the treatment option that sometimes a naturopath recommend. Obviously, I'm not going to go through those, but there is a mixed bag of information in terms of whether they're effective or not. There is a non-absorbable antibiotic called rifaximin that doesn't get systemically absorbed, and it only stays in the bowel, that has the potential to treat small intestinal bacterial overgrowth. But the problem with SIBO is that it can come back. In about 50% of the patients, they actually get relapse within 9 months because you're not really treating the underlying problem that increase the risk of developing SIBO. So sometimes we retreat with rifaximin, which is safe. Sometimes we use promotylic agents to essentially promote movement along the GI tract, so make sure that the bacteria don't have an environment to get stagnant and then grow. And sometimes we implement dietary restrictions, such as low fermented diet. And I would probably suggest that it's better to avoid probiotics or prebiotics, which are kind of food for those bacteria that is packaged in form of the probiotics, because essentially you're adding load to the bacteria in the small intestine. So even though the probiotics are recommended for many physicians, including family docs, and they're readily available over the counter, they are not FDA approved, and we still don't know which bacteria is missing from the microbiome, which is too excessive in the microbiome. So it is a topic that is getting more and more interest from gastroenterologists around the world, and we're kind of just scraping the tip of the iceberg. So diarrhea is another common presentation, and then again, it could be due to multiple causes, and it obviously requires to be appropriately worked up so we can treat the target and treat the treatment according to that. It could be associated with overflow diarrhea, SIBO, lactose intolerance, inflammatory bowel disease, and also microscopic colitis. It could be due to irritable bowel syndrome with diarrhea. It could be due to effect of certain medications, and also because of the associated autoimmune conditions such as celiac or pancreatic insufficiency. And as I said, it does require thorough assessment before we can treat target the treatment. So this is a diet that many of you may have been introduced to. It's referred to as low FODMAP diet. At the bottom of the list, those red ingredients are the food that are high in fermented content. So the bacteria that live in your gut, they love to eat on this type of food, and then they generate excess amount of gas. They can affect further the motility of the bowel, so patients could present with diarrhea and so on. So in most cases, I would suggest that maybe a trial of low FODMAP diet. However, it is a diet that you want to review with a dietitian and ensure that you have a better understanding of it before you carry on doing it, because it is a restricted diet. You have to eliminate essentially all these food at the bottom for 2 to 6 weeks. So you could potentially develop nutritional deficiencies if you remain on this restricted diet for a long period of time. So that's why it has to be done with a registered dietitian. But it has shown to reduce bloating, abdominal distension, and pain in up to about 50 to 60% of patients. And if no relief after 2 to 6 weeks of elimination, then this diet is not the right diet for you, so you should just stop it. And after elimination, you start reintroducing and tailoring the diet based on those identified triggers, so that's why you need to work with a dietitian. And let's talk about some pharmacologic options. Yes. Yeah, so you can actually Google this sheet online. So just Google low FODMAP diet, and this sheet would come up. And also the Monash app I wrote here is kind of like an adjunctive tool you can download on your phone, and it gives you more information on the diet, because this is just a one-page summary, but it actually gives you how information about how to eliminate the diet. It gives you recipes, it gives you some guidance, but generally this is a diet that has to be done with a dietitian. I rarely give this sheet to my patients and say good luck with it, because a lot of patients get confused. They don't know what to eliminate, how to eliminate, when to reintroduce. It's quite overwhelming, actually. If you think about all these ingredients, I know it doesn't project well, but there's a lot of lactose products, there's a lot of fruits, beans, sweeteners, things like that. So there's a lot on this dietary sheet. So that's why I don't want to overwhelm patients with just giving them a sheet of diet and say good luck. So in terms of pharmacologic management, again, it's really important to review your diet and medications list with your physicians. You want to treat the underlying cause of diarrhea, which is sometimes challenging because it may not be just one thing causing the diarrhea. And then some of the symptomatic anti-diarrhea medication I listed out there, most of them are prescription medication, but Imodium and bulking agents such as Salium are available over the counter. But there are other medications that have specific indication, whether it's due to irritable bowel syndrome or after, for example, removing the gallbladder, or rifaximin, which is approved for IBS diarrhea. So I just wanted to briefly talk about fecal incontinence, but I'm just going to breeze through it because it's an area that I'm not actually as involved. And currently, these are the pictures of anorectal manometry. So same principle as esophageal manometry. We can actually assess the strength of the anal sphincter, but it's the area that currently our colorectal surgeons at St. Paul's Hospital are doing the procedure. But the problem is that the current wait time to get on the list for anorectal manometry is 2 years, which is ridiculous. Basically, it allows us to assess the strength of the sphincters, and there are things that we can do for fecal incontinence. But again, it's a territory that the colorectal surgeons are more involved with. Having said that, though, I'm hoping that we will be able to bring anorectal manometry to the motility lab at St. Paul's from a different angle, and then fecal incontinence will remain with the colorectal surgeons, and we're hoping that it would expand so that it wouldn't be 2 years or that I have to send my patients to Calgary or elsewhere for anorectal manometry. I'm going to briefly go over constipation, but the definition of constipation has changed. It's no longer that, oh, I have 3 bowel movements per week and hence I have constipation. I think it's really important for the physicians and patients to get a little bit more history around constipation, because it could be that the frequency has changed. Is it associated with urgency? Like, how long do you spend your time in the washroom? Do you have trouble with evacuation? Some people may actually use to have certain manual maneuvers in order to assist with evacuation, and may even have fecal fecal incontinence because of significant amount of stool sitting in the colon, and just the stool is kind of like seeping around the excess amount of fecal loading. So in order to kind of unify the language between the patients and the physicians, there are actually charts that have been developed, because different people use constipation word differently, and sometimes physicians misunderstand that. But if you actually put the chart in front of the patient and say, what does your stool look like, then we can understand where you are and then how we basically need to approach the trouble with bowel movements. It's also important to mention if there's any associated symptoms like nausea, vomiting, abdominal pain, and bloating, because a lot of time when you say bloating, people think, oh, this is reflux, this is because your stomach doesn't empty properly. But if you have a ton of stool sitting in your colon, you're going to feel bloated. It's important, again, to review the medications and the diet with your doctor. And if you have used laxatives, just jot down the name of the laxatives, how much you took, what was the duration, and what was your response, and whether you experienced any side effects with it. And your doctor may recommend further investigations, including abdominal imaging or colonoscopy. But what are some of the non-pharmacologic methods you can use? Again, make sure you drink adequate fluid, you exercise adequately. Fruits such as kiwi and mango have actually done studies on it, that it shows improvement in bowel movements without causing any bloating, particularly gold kiwi. And then time toileting. So we all have gastrocolic reflux. So, if you think about babies, they eat shortly after they poop. We still have that reflux, so take advantage of that. If you want to take your laxative, take your laxatives before you eat. Give yourself time to eat properly in a quiet setting, and then go to the washroom and try to have a bowel movement. And then soluble fibers such as psyllium is quite helpful, as long as you start in a small amount and gradually increase it, because the fiber can actually cause bloating if you do it too much too quickly. And I'm a big fan of Squatty Potty. I don't know if you guys know what it is. Yeah? Okay. You don't need to purchase the Squatty Potty, and I don't have any share in that company. But basically, you can just buy a stool, like $5 or $10, or 2 phone books, and then just raise your feet above the ground, and that's straighten the angle where the bowel movement can evacuate. There are lots of pharmacologic options, but these are the options that you want to discuss with your doctor before you start using it. I'm a big fan of osmotic laxatives, like PEG laxative, like Restorelax, Miralax, Laxaday, or milk of magnesia, just a magnesium in the liquid form, cheap, over the counter. And they don't make your bowel lazy, or they don't make it used to it. You can take it every day, no problem, and then you can actually remain on it for a long period of time, because I know on the package for PEG laxatives it says don't take it more than 2 weeks or something, but it's actually, they've done studies that up to 2 years it was still effective and it was quite safe, because it just stays in your colon, it doesn't get systemically absorbed, it just sucks food into the stool, makes it softer for it to pass. There are other prescription medications that sometimes we forget that they're available out there that we can provide our patients with, and they've actually, like linaclotide or Constella, has shown to improve abdominal pain associated with IBS, constipation, and also prucalopride. I keep coming back to this drug. I like it in that sense that it has multiple targets, so it can actually promote movement along the colon. So that was a real world of GI manifestation, but essentially, in summary, systemic sclerosis is a multi-system disease that deserves multidisciplinary approach. Gastrointestinal impacts of scleroderma is driven by abnormal GI tract motility. The treatment is tailored to predominant symptoms, and there's ongoing need for research and clinical support and advancement of patient care, and there's absolute need for support and expansion of GI motility in the province of BC. I find it was just killing me to see that there was no motility lab in BC for a number of years, and patients were just going through one gastroenterologist or one endoscopist to another one, just getting scopes done, which is not going to give you the answer. And the motility lab at St. Paul's in its it's just in infancy, but I'm hoping that it would further expand with the support of the foundation and also our generous donors. So thank you for your attention. Any question? Hi.
Hi there. With the PPIs, and you talked about the dementia, is that the true or false?
I would say false.
Okay.
So there's actually no studies showing that it causes dementia. And as I said, the studies that they draw that conclusion that it can increase the risk of dementia were based on observational studies. So essentially they grab bunch of patients in a study, and then they kind of look to see if they develop dementia. But they could have multiple other comorbidities that could have led to developing dementia, and they could have even underlying mild cognitive impairment to begin with. So they were deemed to develop dementia anyways, and it was PPI was just a confounder that they were on. It was just an observational study. So I don't draw that conclusion. And then up to 3 years, it did not show a signal. Yes.
I just wondered if there's any, given that the Scleroderma clinic, for those of us with lung issues as well, happens at St. Paul's Hospital, if there's any talk among that team of doctors of including you on the team.
So I've met with Dr. Dunn and Dr. Wilcox about 18 months ago, was it? Yeah, so this was while I was doing my training at Cedars and in Calgary, to see how I would be able to help particularly with Scleroderma society, because I know the clinics at St. Paul's, and we're lucky to have this offshore motility lab there too. But as I said, we just got the equipment in August, so it's only been 2 months that I've started doing these, but there's a lot of potentials for obviously providing more care specific to the Scleroderma community patients. So I'm hoping that we could further advance that with securing funds from the foundations. There's a lot of potential, so yeah. Yes.
Hi. You didn't mention a drug called Dexilent. Was there a particular reason?
It was on the list, so it's
I'm
one
sorry, I
of
missed
the
it.
PPIs. Yeah, so as
Okay.
I said, generally all these proton pump inhibitors are equivalent. I use Dexilent quite a lot. The problem with Dexilent is that it's quite expensive. The company does provide a patient copay card, which I believe I was told that it can cover up to about 50% of the cost, but I don't know if all family physicians have that. I have it at my office, and I do hand it out to patients that I prescribe Dexilent. But a lot of third-party insurance don't cover it, unfortunately. But it is a long-acting PPI, so you need to take it once a day. But even with Dexilent, there's probably a window of like 1 or 2 hours that have actually done studies on patients with pH monitoring, that they're monitoring their pH, and there's still probably some acid breakthrough. So it is better than other PPI, but if I cannot use Dexilent for whatever limitation, then I use PPI twice a day. So, and then these are the medications that you have to take half an hour before eating, so before breakfast and half an hour before dinner, to kind of like give that 24-hour coverage.
So is there another drug that would be equivalent to Dexilent?
So none of the other PPIs are long-acting,
Okay.
so that means basically 12-hour coverage, more or less, so that's why I use it twice a day.
Good, okay. And because Dexilent isn't covered on PharmaShare, so what was this that you said that your GPs could have?
There's a copay card that the company itself provides.
Okay.
So you just basically take the prescription with that copay to the pharmacy, and they should give you a discount on that card.
Okay, perfect. Thank you. Who's up next? So Michelle's here.
Could you tell me, I read somewhere that PPIs can affect iron absorption in your system. Is that true?
So the way iron gets absorbed in your system is generally a complex mechanism, but it gets absorbed in the beginning of the small bowel. And the most recommendations that you take your iron supplement with acidity, because it just increases the absorption, and you want to avoid calcium at the same time. Now, what PPIs do, they obviously suppress the amount of stomach acid, but it doesn't shut it off, okay? So it doesn't go from whatever it is to zero. You still have some acid production. So even in the studies that they've done and the guidelines we have in place, they don't recommend checking iron levels if the patients are on PPI. So again, I don't say that is a risk associated with PPI. Having said that, though, there may be other reasons that the iron doesn't get absorbed properly. So I would usually try to explore that option before I say it's your PPI interfering with your iron absorption. But if you're taking the supplement, don't take it together.
Yes, does magnesium have a role in diarrhea or your intestinal tract?
So if you remember the list of the laxatives I showed you, I actually use milk of magnesia as one of the gentle laxatives, right? So it can promote movement because it essentially sucks fluid into the stool. So to some extent, yes, it can cause softening of the stool if you're taking it as an additional supplement without diarrhea.
Okay, I was taking it for for another reason, and it has given me one of those stools. Perfect.
That's perfect.
Okay, so, but that would be, you said it would soften.
Yes.
It's made them normal.
Right. So, but what your baseline was and what your stool changed may be due to many other reasons, right? So you could still have an underlying GI dysmotility that will taking magnesium maybe off balance things. But in general, it's known to cause a looser stool. Now, many supplements actually do contain calcium and magnesium together because calcium is a bit constipating, magnesium is a little bit causing looser stool. So in that sense, when you combine magnesium and calcium together, you kind of like don't have the GI side effects of it. But I do use magnesium as a gentle laxative. But probably at a higher dose, it can cause softening of the stool. But if it doesn't impact your stool in any ways, then I think it's fine.
Zantac, what's the news on that?
So I know that there was an FDA concern regarding the NDMA contaminants in Zantac or ranitidine. They say that the amount is quite small compared to what it would actually cause toxicity in human. Having said that, though, I don't prescribe it now. I used to prescribe it for particularly with patients with DEXA, and I used to give Zantac at bedtime to kind of like cover that acid breakthrough I mentioned at nighttime. Now I actually use famotidine instead, which does the same thing that Zantac does, but it doesn't have the concern regarding the cross-contamination. Famotidine, yeah, it's just Pepsid AC basically, but you can get it as a prescription too. Famotidine, Famotidine, at 20 milligrams.
Just got an online question. What is the best medicinal or natural remedy for a chronic cough that is caused by GI effects in scleroderma patients?
That's a talk on its own. So my spiel on chronic cough, particularly when it comes to scleroderma, is that it is most likely multifactorial. It's probably not just GERD, but maybe gastroesophageal reflux disease also contributes to cough. And remember about all the recommendations I've made for reflux, that's still valid for management of chronic cough, which is thought to be due to, or partly due to reflux. Then you go outside of the GI tract, then you think about like postnasal drip, could it be allergies, could be the underlying lung disease, all those environmental factors, things like that. So often chronic cough management, even not in a scleroderma patient, it is a multidisciplinary approach. So I send patients to ENT, respirologists, allergist, immunologists. And there are some, I use cough syrups, the nasal wash or Nasonex. There are some studies showing that gabapentin, which is a medication used for essentially neuropathy or nerve pain, can also at a small dose be helpful for chronic pain or chronic cough. So a lot of time we use these medications that have been classically used for either nerve pain or depression or things like that, not for the sake of that primary indication, but because of that intricate complexity of the system that I said that connects your GI system with your brain. So we can use that in order to help with that. But over-the-counter cough syrups and things like that. So anything that helps with your symptoms of like Hall, anything, but all those things I said for GERD, it's still valid for management of chronic cough.
Hi. I think that works. I have a quick question about gravelly voice. So,
Voice hoarseness, you mean?
yeah,
Yeah.
scleroderma patients complain about that voice getting deeper and gravelly.
Yeah.
Is that related to the esophagus at all?
So the voice hoarseness, again, as I said, it could be one of the atypical symptoms of GERD, right? So there are ways that we can assess whether there is significant amount of reflux coming up into the back of the throat that would be causing those symptoms. But same thing, same principle as chronic cough. Like voice hoarseness can also be multifactorial, including voice exhaustion, and also people develop the habit of going all the time, right? So that itself actually exacerbates the problem. And even chronic cough brings cough. So the more you cough, the more you irritate the back of your throat, and the more it can actually cause cough, right? So it could be a vicious cycle in that sense, but it is one of probably the most frustrating symptoms to deal with, because we don't really have any good treatment specifically for voice hoarseness or chronic cough when it comes to reflux.
A question regarding having your esophagus stretched. How many times can it be done?
So it can be done indefinitely in terms of the numbers of times we can do. Obviously, it's really treating the underlying problem, right? So is it because of reflux that patients keep developing those strictures or narrowing in the esophagus? What is the reason, right? So that's why you're trying to control the underlying problem, because just doing the stretching is just remedying targeting the stricture itself, but it doesn't really treat the underlying problem, right? But as long as we do it safely, which means that we can go from, let's say, like 5 millimeter luminal diameter to 25 millimeter, we do it sequentially in 3 sequences, so just going up by maybe 3 or 4 millimeters each time. But it's not so much like how many times we can do, it's just as long as we're not too aggressive, shooting for the star and the same time dilation, at one-time dilation, we can do it as many times as it takes.
Thank you. I also just forgot what I was going to say. I just had a moment. I can tell when I need to have my knee stretched. How do patients, what would be the symptoms so that they know that they need to speak to their gastroenterologist?
So if they know, because again, it's hard with scleroderma because you can have esophageal dysmotility causing the trouble with swallowing, but if you feel like you've had symptoms that your swallowing is getting progressively worse, and you had an upper endoscopy in the past showing that there was a narrowing in the esophagus, and now a year later, like things have gone progressively worse, then that warrants further evaluation. So if you are concerned about the worsening swallowing, you should mention it to your family doctor. Oh no, that's okay.
One more online question. I can hear the food going down the esophagus. It sounds gassy. Does that mean the scleroderma is progressing?
That's probably very non-specific symptoms, but I would say is that if you're aware that the food is going down, it could be because of the underlying dysmotility. Now, remember what I said about absent contractility, or things are really slow. So if you're actually hearing gurgling of food going down, it's probably because of an underlying movement disorders of the esophagus. Having said that, though, we always put things together. We always ask patients, do you have trouble with swallowing, like actually food getting stuck, like is it regurgitating, which means that it just spontaneously comes back up without any effort, like you're not retching to trying to throw up. Like those are the things you want to mention to your doctor. Any symptoms that is alarming to you, I think you need to discuss it with your family doctor or your gastroenterologist or whoever is taking care of your symptoms.
Thank you very much, Dr. Moosavi. Appreciate that.